and good afternoon. We are here on October 29, 2024, a few days before Halloween. Our patient is here. He's about an hour away. He's from Vero. He is a Florida boy, young. He's got a herniated disc at L5-S1. He was referred to us because his insurance company realized, and this is finally happening, but it's at a very small level, that the alternative treatment is a horrible option. The alternative treatment is called a microdiscectomy. With a microdiscectomy, the surgeon makes a larger incision. They come down the middle of the spine, peeling the ligaments and muscle off the spine. When they get down to the actual bone, we drill a hole in the spine, remove part of the facet joint, and that causes a weakening of the entire spine at L5-S1. They did not want this patient to go through that. They've worked with us in the past. They've seen the great results of the Duke laser disc repair. So they referred the patient to us for a Duke laser disc repair. Let's show the audience what we're talking about, Henry, when we talk about a microdiscectomy. And we are not doing a microdiscectomy, but we're going to show you a microdiscectomy so you can understand the type of internal damage that that procedure causes. In the meantime, I'm going to get us into the L5-S1 disc through the foramen. You ready?
A large incision is made. Muscles are torn from the spine. Substantial bleeding occurs due to muscle trauma. Normal, healthy bone is removed to access the herniation. Stabilizing ligaments are removed in order to access the herniation. An incomplete portion of the herniation is removed. Dense scar tissue forms. Weakened bones can fracture, leading to instability and pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
Welcome back. You can see from that video we just showed you that the microdiscectomy surgery is very invasive and destructive internally. It causes long-term does is really relieve a pinched nerve causing leg pain or sciatica. Most people with a disc problem or a disc herniation also have back pain. This patient also has back pain along with his left leg symptoms. Okay, getting close. Shot. How are we doing, Dr. B? Can I proceed?
How are you doing, my friend? You okay?
Our patient is just waking up for this part. We need his cooperation. Don't move. You're doing great. Any pain? All right, we're right at the back of the disc, right in the herniation. I can feel the herniation with the tip of the needle. Jordan, show the audience the tip of the needle. Perfect. Yep. I hope you guys can see that. Henry, you can see it?
Yes, we can.
All right. The needle tip is right where the herniation is. Reliable? All right. So this is L5. Let's get an AP, S1, and his herniation is here on the left side. We're actually coming around the spine. We're not going to remove any bone. We're not removing ligament. We're not removing muscle. We're not taking anything out. We're actually going through a natural opening on the side of the spine. You guys can see it from the AP view. The needle is coming in from the side through a hole that's already there. That is the beauty and brilliance of this procedure, is that it does not take away any bone or ligament or muscle. All right, shot. I'm happy. We are in the disc at this point. And I'm just going to give Dr. Bernays another minute to see if we can get our patient awake. It's a bit of a squirmer, so we had to put him down. make them deeper asleep. Any questions, feel free to type up the question. In the meantime, we're going to show you guys a video explaining. Is he just not really cooperating?
No.
Then just keep him down. I mean, it's mostly leg anyway. We're going to show you a video, folks, that explains the 20 different causes of chronic back pain. And more importantly, since we know the cause, we can fix it. Shot. There's his tear. You can see it, Shot. He does not like that. It's leaking out into the epidural space. One more time. Shot. All right, yeah. So the tear is actually low. You can see it at the bottom of the disc right there coming out, and that's where the herniation is. You can see the dye leaking out around the nerves. All right, Henry, let's show our audience the 30 causes of chronic back pain. What are they?
Copy that.
I'm Dr. R. Duke Majan with the Duke Spine Institute, and we're going to discuss 30 causes of chronic back pain. Chronic back pain is back pain that lasts longer than 6 weeks, and there are 30 causes of chronic back pain. The most common cause is going to be a disc injury. Disc injuries such as disc herniations, disc bulges, disc ruptures, degenerative disc disease account for 86% of chronic debilitating back pain, and they are totally fixable with the proper treatment. The best treatment for disc injuries is Duke laser disc repair. Let's take a look at the 5 lumbar discs that can be injured. The most common disc to be injured is L4-5, followed by L5-S1, then L3-4. The L1-2 and L2-3 discs are far less commonly affected. Next, we have facet joints. Facet joints are small joints located behind the discs in the back of the spine. There are 10 facet joints, each paired left and right, L1-2, L2-3, L3-4, L4-5, and L5-S1. The most common facet joints to cause chronic back pain are L4-5, followed by L5-S1, followed by L3-4, in that order. After the facet joints, which account for approximately 10% of chronic back pain, we move on to the sacroiliac joint. The sacroiliac joint accounts with the piriformis muscle for approximately 4% of chronic back pain. The sacroiliac joint is a joint located between the tailbone or sacrum and the iliac bone. There is a left and right sacroiliac joint. In this diagram, you can see the joints turning red, indicating inflammation and pain either in the left or right sacroiliac joint. These sacroiliac joint injuries and pain can be treated most effectively with the Duke plasma rhizotomy of the SI joints offered at Duke Spine or Duke Joint Institute. The 4th most common cause of chronic back pain is a piriformis muscle injury. The piriformis muscle is located in the buttock, and there is a left and a right piriformis muscle. The muscle gets torn, unfortunately, when people bend the wrong way. This usually occurs in patients with orthopedic problems such as hip pain, knee pain, or back pain. By bending improperly, they put the muscle under too much stress and they tear the muscle. The torn piriformis muscle causes severe debilitating pain in the top of the buttock. There is a left and a right piriformis muscle, and this can be treated most effectively with the Duke piriformis muscle release. This is performed percutaneously with a 4mm incision. The sciatic nerve does run through the piriformis muscle, and many patients with piriformis muscle syndrome also have sciatic pain down their legs, with pain, numbness, tingling, and weakness in the leg that's affected on the side of the piriformis muscle. Piriformis muscle can be treated with injections such as steroids, Botox, PRP, or stem cells. However, those injections always wear off and the patients end up coming back with the piriformis muscle pain that reoccurs. The most definitive treatment for permanent relief of piriformis syndrome is a piriformis muscle release. Next, injuries to the bones of the spine, touches the vertebral bodies, with trauma can cause fractures of the vertebral body. Vertebral body fracture is diagnosed with X-rays or CAT scan or MRI, and they're treated with injection of cement into the vertebral body. Looking at the vertebral bodies, the most common to be affected is L1, followed by L2, then L3, L4, and L5. The sacrum can also be fractured. Finally, the coccyx is the last cause of chronic back pain. You can see in the diagram the red coccyx at the bottom. This comes usually from an injury where the patient falls on their bottom, sustains pain at the tailbone, and this can be treated with injections of the coccyx ligament. These are the 30 most common causes of chronic debilitating back pain, the most common being the disc, causing 85% of chronic back pain, followed by the facet joint, causing 10% of the chronic back pain, followed by the piriformis muscle and sacroiliac joint, which cause 4% of chronic back pain, totaling 99% of chronic back pain, which is totally fixable and curable with the right treatment. Thank you. I'm Dr. Duke Majan. Thanks for joining us. Welcome back. And you can see from our animation video that back pain has many causes, 30 actually, and of those 30 causes, the most common is a disc injury. Disc injuries account for 85% of people's primary cause of back pain. Primary means that's the main cause. All right, in the meantime, while you were watching your video, we were able to get into the L5-S1 disc through the left L5-S1 foramen. We now have an endoscope inside the disc. We're using our laser to clean up the herniation. This is the herniation right here. We are in the herniation. We are basically using the laser to break the herniation up into small pieces and remove those pieces. Now, those pieces of herniation, they do something when they're sitting inside the annulus, which is not, they're not supposed to be in the annulus. They're supposed to be in the nucleus, in the middle. But the annulus is the outer wall. And when the annulus gets torn, as it always does in a herniated disc, the herniated fragments or nucleus get stuck inside the annular wall or the annular tear. The tear is about 2 centimeters thick. And so you get a lot of pieces of herniation stuck in the tear. And that causes an inflammatory reaction. The body has an inflammatory response inside the annular tear, trying to get rid of those pieces of herniated nucleus that's not supposed to be there. This was discovered at Duke Spine Institute. This is a finding that I discovered about 18 years ago, and I published the results of my finding in the medical literature in our first paper on the Duke laser disc repair procedure, where we described going in and debriding the annular tear. But this whole idea that the disc is the source of back pain, most doctors don't even realize the disc is the source of back pain. I'm getting a shadow or a light, and I think it's that light. That's better. I think that's better, yeah. Thank you. All right. If you have questions, feel free to ask them. Type them up. We are live streaming this surgery on YouTube, X, LinkedIn, and Facebook. Any questions?
At this moment, no current questions. So in the meantime, why don't we show the audience of how a herniated disc causes back pain?
I think it's a great idea, Henry. Thank you.
Of course.
Disc injuries start with an annular tear, damaged nucleus. Pulposis herniates into the annular tear. The herniation triggers an inflammatory response within the annular tear. The inflamed annular tear generates pain signals. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
And welcome back. You can see from the video animation that we just showed you how the annular tear occurs with trauma and injury to the back. And then regular bending, lifting items, bending over at the waist, tying your shoes, putting on your shoes, picking something up from the ground. All of those movements cause pressure in the disc, and they push these pieces right here, these little pieces of material, they push them out of the disc and they push them into the tear. So they try to escape, sort of like uncapping a bottle of toothpaste and then squeezing it. You're going to get some of that toothpaste stuck in the neck right where it comes out, right? And so what I'm doing here is I'm coming in with a laser, cleaning the tear, getting rid of the pieces of herniation that are stuck in the tear that are causing the inflammation, which causes irritation of nerves. The inflammation is causing the back pain by irritating fine nerves, small nerves that are located in the back of the disc. These are branches of what's called the sinovertebral nerve. Now the sinovertebral nerve is what's responsible for back pain and neck pain when you have an injury to a disc. We're going to show you now a video that explains how the laser can be used to debride the tear. It's called an annular debridement. It was first discovered and described right here at Duke Spine Institute. It's part of a procedure called the Duke Laser Disc Repair. I know we have a question from the audience. I'll get to that in a moment, but first we want to show you all how this surgery actually works to remove the herniation and get rid of the back pain as well as the radiculopathy.
Disc injuries are a common cause of chronic back pain. The inflamed annular tear causes back pain. A 1/4 inch sized skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website or call us at 1-800-FIX-MY-BACK, 349-6922.
Welcome back. You can see from our animation that we just showed you that the laser can be used to remove the herniation out of the tear. That's where all the back pain comes from, is that tear. And that inflammation spreads to the nearby nerve roots. The nerve roots are literally next to the herniation. So as the tear gets inflamed, as your body's trying to remove the herniation out of the tear, what happens is it gets onto your nerve going down your leg and it causes sciatic pain. We call it radiculitis, inflammation of the nerve root. These are all pieces of herniation. And most people think of a herniation as being one big piece of disc material, but it's pieces. And the average, I would say, that I've seen over the years is about 25 pieces of herniation per disc that's herniated. So, all right, we've shown the 30 causes of back pain. We've shown how a herniated disc causes chronic back pain, laser.
Correct.
We've shown how the laser works, right?
Correct.
There's the inflammatory tissue right there. It's pink. You guys see that? That's where all the back pain comes from. We're going to go clean it up. Why don't we answer some questions then, Henry?
Yes, this is coming from Michael on Facebook.
Hi, Michael. Thanks for asking.
You
Joining us.
asked another question. The first question we're going to is, hi, Dr. Duke and team. Hope everyone are all well. Just wanted to say congratulations on the new website, Dr. Duke. It looks amazing.
Oh, thank you, Michael. I really appreciate you saying that. It means a lot. And just to say, you know, we've had some serious code issues with the new website, and we've been trying to clean up those issues and basically technical SEO issues that have affected our performance of the site, and some technical issues with, you know, presenting the animation. So I appreciate your comments. It's not perfect yet. We're working on getting it better every day, and I appreciate everything you've said about it. Thank you.
My question is, when the disc is collapsed, is it more likely the tear can run all the way around the back of the disc? And
yeah, so let me answer that first. So the tear that we're talking about that Michael's mentioning is the posterior annular tear. And it's really quite simple. If your herniation is on the left side, then it's a left tear. If your herniation is on the right side, it's a right tear. If your herniation is in the middle, it's a middle tear. But most tears, in my experience, are really bigger than just left and right. But it turns out that the pain that people get from a disc injury and an annular tear is typically pain originating from the part of the tear that we're able to get to at the foramen, the neuroforamen. It's almost like the annulus right at the neuroforamen is full of little pain fibers because the nerve roots run right behind the disc right here. This is the only place the nerve roots are. And I almost feel like it was designed that way by God to basically tell the patient, hey, you've got a problem with your disc. You've got a tear and a herniation. And here's your back pain, making you aware of it. But if you keep doing stuff with your back, heavy lifting, you're going to push more herniation out, which is then going to cause nerve damage. And then you're not going to be able to walk or run because your nerve will be pinched by a herniation that's even bigger, and you'll have weakness. And then you won't be able to outrun those lions and bears and tigers. They're going to eat you, right? So evolutionarily, if you think about it, it makes sense that people with a tear in the back of the disc, right where the nerve root is, those tears would be symptomatic and cause awareness of the problem so that you can modulate your behavior and learn to be more careful and not cause more herniation so that your nerves will stay functional and you can outrun threats to your life. It's basically got a survival advantage and evolutionarily. And if you think about, 1,000 years ago or earlier, humans had to do a lot of surviving. All right, look at that, beautiful. We are just finishing up this herniation and it's going well. I know Michael had another question. By the way, that is fat, that yellow stuff, and it's literally encased around the nerve root of the L5 nerve root. And the reason for that is the nerves, remember, they are very active, sending electrical signals all the way down to your muscles, right? And they use a tremendous amount of energy. Because nerves, peripheral nerves, are not part of your central nervous system, they're not part of the brain or spinal cord, they can actually use fat as an energy source, whereas your brain and spinal cord never ever use fat as an energy source. They only use sugar, carbohydrates, aka glucose. So whereas the nerve roots are part of the nervous system that can use fat for energy, and that's why there's lots of fat around the nerves here in the foramen, the brain and spinal cord cannot. So that explains the fat around the nerve roots. Plus, it also acts as a protection, kind of like a bumper in case you do get a herniated disc like he has. All right, we'll take some more questions.
Next question coming from Michael once more on Facebook, asking, also, can the DLDR help with movement? I find as I bend forward, I feel a type of pressure pain increasing the further I go.
Yeah, I believe you're talking about your back pain, right? And if you're feeling a pain bending forward, it's probably a discogenic pain, because the other main cause of pain is the facet. And facet pain is worse when you bend backwards, not forward, backwards. So facet pain typically gets worse bending backward. Disc pain typically gets worse bending forward. And if you have a fractured vertebrae, which you probably don't have, but that would be painful when you bend forward as well. All right, almost done. I have about a minute left. We'll take some more question and answer if there are more questions. Otherwise, I'm just going to keep trying to remove as much of this herniation as I can. And what I tell this patient, and I tell every patient, we will never get all of your herniation out. It is impossible. You cannot remove 100% of a herniation. And if you look at the MRI, you're still going to see herniation. That's because the goal is not removing the herniation. The goal is to get rid of symptoms. And it turns out that most of the herniation is asymptomatic. It doesn't cause symptoms. It's only a small part that does. Yeah, I need a few more minutes, so. Any more questions?
At this moment, no current questions.
All right. Since we've been talking about the herniated disc, we've been talking about discogenic pain and the causes of back pain for people, I think it would be helpful to show people the second most common cause of back pain, Henry, which would be the facet joints.
Of course.
That's not the case in this patient. We don't think this patient has facet pain. It's too early to say, but many people do, because when you injure your disc, you can also injure your facet. By the way, that's the base of the herniation right there. You guys see it?
Yes,
I'm
we do.
literally inside the herniation, trying to use the laser, which is 1 millimeter wide, 1 millimeter. I'm using that laser to basically chop out or blast out, vaporize little pieces of herniation, slowly shrinking down the herniation. There's a name for this. In medicine, it's called debulking. Debulking. We are debulking the herniation. It means taking the bulk out of it. All right, well, you show the audience the facet animation. I'm going to keep chipping away at this herniation. I'm almost done. I just want to make sure we're not leaving behind too much. I like to get about 50% or more. That's my goal. All right, you can see from that animation that the facet joints in the back of the spine can also cause pain. And the way they do it is through the same process. It's called inflammation. Inflammation is your body trying to fix a problem, and it unfortunately causes sometimes more problem than it fixes. And the facet syndrome is an example of that. Just about done. I'm just trying to clean as much of this herniation as I can with the laser. Any other questions?
At this moment, no current questions.
All right, I'm going to do just a little bit more right there. That's the posterior longitudinal ligament called the foraminal ligament in the foramen. This is a big herniation, by the way. The more of this I take out, the higher the success rate of the surgery. So I'm going to try to remove as much as I can. You can see the laser is just shrinking it up, right? Going to do one last sweep. By the way, he's kind of a younger guy. I'm not going to give you his age, but he is younger. And that works to his advantage. I'll tell you why. What limits my ability in transforaminal lumbar surgery to get medially towards the midline is the facet joint. And the facet joint is, in his case, quite normal. So because of that, I can get more medial than somebody who's older. Like right here, being able to see this like I can right now at 12 o'clock, that's amazing, you know? I wouldn't be able to do that in somebody with big facets. You know, somebody who's like 70, 80 years old, I wouldn't be able to do this right here. Berndes almost done, probably 1 minute. I'm seeing the posterior ligament there. That's a good sign. This thing is like a rock. See how scarred up it is?
Yes, we do.
It's literally like a rock. This is not an easy case, but it's going quite well. And I think he's going to do really, really good. Let's get the grabber one more time. I probably shaved down about 50% of the herniation at this point.
We have another question
Yes.
coming from Michael once more on Facebook, asking, do you find the 51 disc to be the most challenging? Oh, the L5-S1, excuse me. Do you find the L5-S1 disc to be the most challenging, Dr. Duke? Most
Yes.
surgeons I have spoken to can't even attempt it.
You are correct, Michael. L5-S1, they don't even attempt. Surgeons won't try because it's too hard. But I do it all the time. I've learned how to do it properly. There is a trick to doing it, and I've had to figure it out. But the master surgeon that taught me, Dr. Anthony Young, he was able to do 5-1 most of the time. But he said to me one day that other surgeons around the world won't even do it. He was the only one who did 5-1, L5-S1. And I learned from him, and I developed a trick of my own, and I've been able to do 5-1, and I haven't had any issues getting there. All right, that is about probably 60%. And let me just grab one more time, see if I can get any more of it. But that should be enough to cure the back pain and cure the leg pain. This is kind of a hard herniation, you know. What I'm feeling here is it's got so much scar tissue. It's pretty impressive. Let me go one more time.
We have another question
Yep.
coming from Ping on Facebook, asking, hi Doc, just tuned in.
Laser.
How long do you think this has been since initial injury, and what would you expect to see from a 6-year herniation?
Yeah, great question, Ping. I think this herniation is not new. I would say, based on what I'm seeing with the amount of scar tissue right here, and the size of the herniation, the firmness, and some of this calcification right here, I would say this is probably about 3 years to 5 years old. This one that I'm working on. A 6-year-old herniation could look very similar to this one. Very similar. Very similar. All right. There's some veins and fat in the epidural space, and you can see I've gotten as posteriorly as I can towards the nerves, and I just cannot get any more. But the good news is, see that white string right there, like a white right there? That's
Yes, we do.
the posterior longitudinal ligament. And typically a herniation will push back against that and push the PLL backwards. So by the fact we're seeing the PLL right now, that's a good sign, meaning that we've pretty much gotten most of the herniation out. So I'm happy with that. And we're pretty much done. Okay? The nerve root's going to be buried in that fat. There's the disc where the tear was. That should heal up nicely. His surgery went very well. I'm pleased. I couldn't really grab or get out any more of the herniation. Let's go. Any questions, feel free to ask me. We're going to put some antibiotic.
At the moment, no current questions.
All right, great. Wow, he did really well. This was a single level L5-S1, transforaminal, endoscopic, laser-assisted, Duke laser disc repair. Duke Spine is the only place in the United States, or actually the world, that does this endoscopic laser annular debridement. We're the pioneers, the first ones to do it. There's my technique I did 19 years ago and published. First to publish it in the world, the first to do it. Now we're doing all kinds of stuff. We do piriformis muscle releases, minimally invasive. We do facet treatments and SI joint treatments for facet joint pain and sacroiliac joint pain. Here's some of the herniation we took out. You guys see this?
Yes, we do.
A lot of it went down into the bag. and off the table, but probably about half of it's there. Luis collected it all, and we're going to send it off to the pathologist. But you can see that it came out in a lot of pieces. All right. Thanks for joining us. Any other questions?
No current questions.
Have a nice day. This is our last surgery. We did 5 cases. We broadcasted 3. The other 2 were done in room 2, which we don't have broadcasting equipment for. We'll be back next week on Tuesday. Have a nice day.